All right, so good morning, everybody. I am delighted to introduce Modele Ogunniyi, who's our LOC Distinguished Speaker today to give cardiology grand rounds. Dr. Ogunniyi comes to us from Emory, Atlanta, where she is an associate professor of medicine, and she is associate director of their heart failure program, which is how I found her to give our grand rounds. She went to undergraduate in Nigeria and then came to the United States, where she got her master's of public health at Johns Hopkins. She then went to the CDC, where she did the enviable CDC fellowship that I know several of our infectious disease people like to talk about how they did it and lord over us how much more they know about the pandemic than we do. And then to Morehouse for internal medicine residency, Vanderbilt for cardiology fellowship, and then back to Atlanta. You must have really liked it there at your CDC time. And where she has established a career in looking at inequities in hypertension management. She's on multiple committees nationally and working on this. She's on the multiple clinical trials. And I'm really looking forward to hearing her speak today on advancing hypertension control towards equitable outcomes. Thank you, Modele, for coming.
Thank you
for coming.
Thank you for that kind introduction, April, and good morning to everybody. I have no relevant financial disclosures related to this presentation. So over the next 45 minutes or so, I thought that we will review hypertension in terms of its epidemiology, the impact of social determinants of health, and briefly look at disparities in hypertension control. And if at all, what I want everyone to take away is that we need to think outside the box when it comes to management of hypertension. So I hope to leave you with practical, patient-centered strategies to improve blood pressure control and to impress upon you the importance of multidisciplinary team-based care and a connection to the community in managing hypertension. All this center around the principle of achieving equitable outcomes in hypertension management for our patients. It's no surprise to you all, everyone knows that hypertension is the leading cause of cardiovascular morbidity and mortality, not only in the US, but globally. But when we think about the prevalence of hypertension, by that I'm defining hypertension as a blood pressure greater or equal to 130/80. The prevalence approaches almost 50%. It's actually 45% and 47% really in the recent heart disease and stroke statistics. We all know the racial and ethnic disparities in hypertension. There's been a lot published about that. But one thing to note is that Black adults, whether in the US or other countries, have one of the highest rates of hypertension. Although we see increase in rates of awareness, people are being treated for hypertension, we as a nation have not been able to achieve hypertension control. It's a persistent public health crisis. And as you will see, as I will share with you in subsequent slides, the control for hypertension is suboptimal, especially for minoritized racial and ethnic minority population groups. So this is data from the recent heart disease. It's published annually by the American Heart Association, looking at trends in the prevalence of hypertension by race, ethnicity, and sex. So I will walk you through this slide. You can see this is the NHANES data, the National Health and Nutrition Examination Survey. It's conducted sometimes every year, but they usually look at trends in risk factors, and this is the one that was done for hypertension. So stratifying by race as well as gender, I want you to notice that the Black population group tends to have a higher prevalence of hypertension, approaching over 50% when you compare to other groups, and particularly Black males have a higher prevalence of hypertension. So this is the same slide, but I'm pulling out the most recent data that we have. About 120 million Americans, almost approaching 50% of the population of adults, have high blood pressure. And when you look at the gender differences, you see that males have almost 50% of males have a higher prevalence of hypertension. But just like I showed in the other slide, the prevalence of hypertension in Black males and females are almost approaching 60%. When we talk about disparities, we look at gender, we look at sex, we look at race. But one interest of mine also is looking at geography. In fact, also looking at rural versus urban differences. I'm sure this group is we are aware of the stroke belt, which is where I am. When I was preparing the slides, I was looking at Washington, and I see that it looks as if hypertension might not be a big problem, but I guess after talking with Dr. Roth and and the work he's doing along hypertension, I think it's great that your division is contributing to hypertension. So when we talk about hypertension, I'm sure you've seen the slide. People talk about the extent of awareness, treatment, and control in the general population. This is data from NHANES, also stratified by gender as well as race. And we're doing a good job. People are aware that hypertension is a silent killer. I mean, if you talk to your patients, they know that, oh, high blood pressure can kill you, And I think that there are a lot of the government has put in a lot of money, as well as private organizations, really into increasing awareness. There are a lot of public education campaigns about hypertension. So we're not doing 100%, but we're doing really good in terms of letting people know about hypertension. And even when you look at it by race, you can see even among Black females, they have the highest awareness about high blood pressure. But when we think about treatment, the percentage starts to go down, and we'll talk about that. But where I really spend most of my time is really in the arena of control. So despite the fact that we have a lot of medications, the medications to treat hypertension really are cheap. Patients can get them at least a 90-day supply of most of the medications for $10 at Walmart. We are not doing a good job with controlling hypertension. We have a lot of clinical trials going on. We have the renal denervation treatment, just a lot of novel things. But why is it that when we think about controlling hypertension, we see one, gender disparities, as well as racial and ethnic disparities? If you look at the Hispanic male, they have the worst control rate out of all the racial and ethnic subgroups. So already one recurring theme you'll see in my talk is that hypertension control is worsening in the US. In Europe, actually in their guidelines, their blood pressure goal is 140/90. So Modele and colleagues looked at hypertension control recently in a publication in JAMA. And whether you look at you set a blood pressure goal of less than 140/90 or 130/80, we are not doing a good job with hypertension control. So when you look at a blood pressure of 140/90, you can see that the rate of extent of control is actually getting worse. But we talk about tighter blood pressure control, and in the US, we define blood pressure control as 130/80. It is amazing, or it is frightening, I don't know if that's the right word, to see that only about 1 in 5 adults with hypertension have a controlled blood pressure. So that is food for thought for all of us as clinicians, as public health practitioners, to think about what to do. So why are blood pressure control rates poor? It's multifactorial. this quad shows the influence of environment and society, the impact of the health system, even the patient, and us as clinicians. You know, how many times have you seen, and I usually work with fellows, and they come, they present a patient, and the blood pressure is like 150/90. And you say, oh, so what are we doing about this blood pressure? And they say, oh, the patient, he was late for his appointment, he was rushing, he couldn't find somewhere to park, oh, he just had coffee. The clinician, and I'll show you some data later, but the inertia for us as clinicians to really titrate blood pressure medications and achieve goal blood pressure medications is really, really appalling. And of course, the competition with time, you know, are we measuring blood pressure correctly? Do our staff know how to measure blood pressure correctly? You know, cultural competence, all these things affect blood pressure control. One, a special consideration, and one of my interests is cardiovascular disease in women. And in a paper we published in JACC, a review on race, ethnicity, and hypertension, we devoted a section to hypertension disparities in women. So disparities in terms of their awareness, treatment, and control, and also hypertensive disorders of pregnancy. So if you look at the recent heart disease and stroke statistics, when you look at trends, like I showed you before, in trends in hypertension, treatment, and control, they actually were large increases. But when you look at the trend in Black females, there was a substantial decrease, almost to the order of 10%. And you all are aware of the issues with Black maternal health. We know that chronic hypertension in pregnancy, defined as blood pressure, systolic blood pressure greater or equal to 140, or diastolic pressure greater or equal to 90, either before pregnancy or less, or during pregnancy, between over a 40-year period, there was an increase in 13-fold. Reasons for this could include, we're more aware of it, there's detection of it, but despite, when you control for all of these things, there's some unaccounted factors for why there's this huge disparity. And then when you break them down by race and ethnicity, Black women actually have a persistent 2-fold higher rate compared to white women over this 40-year period. So I think that as we think about hypertension control, I think it is time for us to think about things outside the box. I call myself a public health physician because I look at every patient that I take care of in the context of their social, economic, political, and cultural environment. I'm sure you're all familiar with social determinants of health, but this definition from the Healthy People 2030 is a definition that, for me, it's simple and easy to grasp what this really means, because a lot of people talk about social determinants of health, but what does it really mean? So I like this definition, which says that social determinants of health are the conditions in the environment where people are born, live, learn, walk, play, worship, and age. So find themselves, and that affects a broad range of health, of their functioning and their quality of life, and really plays a role in their outcome and risk. And the components of social determinants of health include access to and the quality of education that people receive. We talk about healthcare, not only access to healthcare, but the quality of healthcare that is received, economic stability, social and community context, and the neighborhood and built environment where patients find themselves. So this is a slide, I'm sure most of you may have seen it, but we always have to think about the impact of social determinants of health. And they have a tremendous impact on an individual's health, regardless of age, regardless of race or ethnicity. This slide demonstrates the impact of social determinants of health. So 20% of a person's health and well-being really is related to access to care and the quality of healthcare services they receive. But guess what? The physical environment, the social determinants of health, and the behavioral factors drive 80% of health outcomes. So I think that it is time for us to think. We spend most of our time in the clinical treatment domain, but when we think about the fact that 80% of health outcomes are driven by the physical environment, social determinants of health, and behavioral factors, I think it's time for us to think about how to approach cardiovascular disease, how to decrease the burden of disparities in cardiovascular disease, because this drives outcomes. And it doesn't matter your race or ethnicity, it doesn't matter how old you are. We really need to think about the impact of social determinants of health. So the American Heart Association in 2015 came out with this scientific statement. And really, I will encourage you to read it if you haven't. But in this scientific statement, they really talk about the impact of social determinants of health, how they determine risk, as well as cardiovascular disease outcomes. But it was the first time that a national organization called out racism. So people, when you talk about any form of cardiovascular disease, hypertension, acute myocardial infarction, when people talk about lipids, they tend, when they talk about, even for hypertension, I mean, I'm sure you've been to talks where people talk about modifiable and non-modifiable risk factors, and race and ethnicity is usually listed. But I want to put forth today that actually race and ethnicity is not the risk factor, but the risk factor really is racism. So talking about racism and discrimination, when you think about interpersonal discrimination and racism, this really are psychosocial stressors that contribute to adverse health, including hypertension and other cardiovascular disease. In fact, in the Jackson Heart study and in the Mesa study, they did some analysis and found out that discrimination contributes to the development of hypertension. But what really, how it contributes to the development of hypertension is really because patients with hypertension develop coping mechanisms, such as unhealthy diet, they're depressed, they don't exercise, they don't have access to safe sidewalks. All these coping behaviors actually contribute to development of hypertension. So in the Jackson Heart study, in a cohort of almost 2,000 Black adults who were free of hypertension, that is, at baseline, they did not have high blood pressure. Lifetime discrimination was associated with the incidence of hypertension in this cohort. Similarly, in the Mesa cohort, over 3,000 adults, lifetime discrimination was associated with a 35% higher risk of incident hypertension among adults who did not have hypertension at baseline. So in this American Heart Association statement, they conclude and say, structural racism is a fundamental driver of health disparities in cardiovascular disease and associated risk factors. They say that structural factors contribute to poor access to heart-healthy foods and the abundance of food deserts in racially segregated neighborhoods. In the 2019, the American Heart Association put out structural measures for the diagnosis and management of hypertension. And throughout the rest of my talk, I'm going to be highlighting a couple of them. I've already talked about social determinants of health. It's actually a structural quality measure. And one of my objectives was that I was going to tie all of this into a patient-centered approach. So I think that whatever strategies we come up with have to center around patients and their support system. So in this structural measure document, one of their goals is to demonstrate infrastructure and personnel that assess and address social determinants of health in patients with high blood pressure. And that comes from the prevention guidelines. And I'll share with you in upcoming slides some of the ways that we have done that at Grady Memorial Hospital, which is a safety net hospital similar to your safety net hospital here in Seattle. So there are a lot of tools out there. In this day of electronic medical records, there are tools that are incorporated into the electronic medical record. There's some people still use paper tools, but I wanted to highlight some of the tools that I am familiar with that really help us to assess social determinants of health. And not only, I guess, to address social determinants of health, you have to assess their existence and then develop programs around trying to address adverse social determinants of health. So first, I'll talk about the Prepare tool that comes out of the National Association of Community Health Workers and their partners. It has 16 core measures that looks at personal characteristics, it looks at family situations, home situations, it looks at the financial aspect, and really social and emotional health. There are optional questions for whether a person has been incarcerated, whether they're a refugee, and really safety issues with regards to the home or with loved ones. This is a tool at our at Grady Memorial Hospital. We use EPIC. This is actually a panel from one of my patients that I saw in clinic a couple of weeks ago. We have social determinants of health as a model built into EPIC. So some of the things we look at, I didn't put all the things, we look at financial resource, strain, we look at housing stability, whether they have experienced homelessness or have they ever experienced homelessness in their lives. We look at transportation needs, and we look at food insecurity. I particularly want to talk about food insecurity because this is a program that Grady Health System has that I'm really proud of, that I think that has helped us to address food insecurity. So when patients come, and this is not done by the physician, this is done by the medical assistants at triage. So these are the questions, 2 questions addressing food insecurity. The medical assistant asks, within the past 12 months, were you worried that your food will run out before you got money to buy more? Or within the past 12 months, were you worried that the food you bought will not last, or you don't have money to get more? And if a patient answers one or more, so they don't have to answer both. If they answer any variation of true, either sometimes true, often true, patient, never true, sometimes true or often true, and they have a diagnosis of uncontrolled diabetes or hypertension, it automatically generates what we call a BPA, Best Patient Advisory, and the patient is enrolled in our food as medicine program. So this is a flyer that we give patients, we give to staff. We have a food as medicine prescription program to let people know that eating healthy food is equally as important as taking your medicine. So that's why we call it food as medicine program. And patients can enroll by walking into a food pharmacy that is located right outside of a hospital. In fact, that food pharmacy now, in the past, used to be McDonald's, but now it's where patients can go and get free fruits and vegetables. They can get nutrition education. They can participate in cooking classes, and it's open to employees as well. So this innovative food as medicine partnership really addresses food insecurity, which is one of the adverse social determinants of health. And it's a program we started about 2 years ago. So initially was rolled out in the primary care clinic, but now, or as of a month ago, has been expanded into cardiology. So patients that we see that have a diagnosis of hypertension and have answered sometimes true or always true to 1 or 2 of the food insecurity questions actually are eligible to be enrolled in our food as medicine program. And in Atlanta, food insecurity in our patients, who come to Grady, because of Grady, I shouldn't assume that everybody's familiar with Grady, but Grady is the safety net hospital for Atlanta. It's over 960 bed hospital. We are funded by the Fulton and DeKalb County, which really are the counties that surround Grady. So patients who live in that county can come to Grady if they're uninsured to receive free care. And even patients who live outside of the county, they have a financial assistance program where they can receive like tier-based access to care. So like I said, it's open to patients, to visitors, to employees, to anyone can walk in and get a food prescription. So I already talked about this. It's something that's done by medical assistants, and that brings me to that multidisciplinary team-based approach to address disparities in hypertension. I, as a physician, don't have to do this. The MA, when they're triaging the patient to get their vital signs, ask these two simple questions. And if a patient has a problem list or blood pressure that shows that's greater than 140/90, or hemoglobin A1C that for some reason, I don't know why, they pick the hemoglobin A1C of greater than 9, it triggers a BPA, a best practice advice, and the patient is referred to the food pharmacy. So this is how it looks. In EPIC, we have the same social determinants of health will, and if those questions are triggered, it automatically puts in a red bar showing that this patient is experiencing food insecurity. I already showed this. It's done by a medical assistant. Once she determines that the patient is experiencing food insecurity, they give them this flyer, they explain to them, they have talking points. So this medical assistants serve as coaches. You know, they tell them that part of your care is really eating healthy fruits and vegetables. You don't need an appointment as you're going out. And the food pharmacy is strategically located at the entrance where patients come in. And they don't need an appointment, they enroll, and in that visit, they receive fresh produce. So this is actually a picture of our, what we call the Jesse Hill Market. It's a partnership with the Atlanta Food Bank. It is open Tuesday to Friday. Anybody can go in there, get lunch. They have cooking classes. Patients go there to receive their fruits, and their fruits and their vegetables, weekly as they need. So this is an example. This is not an example, but actually a picture of the teaching kitchen where they have cooking classes. They provide education for life skills, teach them about diabetes, nutrition, their hands-on cooking. As you can see, these people were wearing masks. In the time of COVID, some of it was done virtually, but now we're back to doing hands-on cooking classes. It's open, like I said, to both employees as well as patients. This is had the opportunity to go into the freezer, huge space where this is one of the managers of the Jesse Hill Market. So patients can come in without an appointment to receive fresh produce. The produce is provided weekly by the Atlanta Community Food Bank at no cost, both to our patients. So patients who have those food prescriptions just walk in and receive their produce in this Jesse Hill Market produce bag. So I already talked about this. It goes on for 3 months. It's renewable for 1 year. It's no cost. And apart from receiving the foods, we also have classes to really make sure that the patients right now they're collecting measures, weight, BMI, quality of life issues, and they're in the process of analyzing that data. But preliminary data has shown really the effect of establishing this program in achieving blood pressure control. So pivoting now, I've talked about like our local strategies to increase blood pressure control. In part of some of the work I do, I serve as co-chair of the National Hypertension Control Roundtable, which was really set up about 2 years ago as a result of the Surgeon General's call to action to control hypertension. So in the Surgeon General call to action to control hypertension, they really identify 3 goals. And it is if I employ you, if you haven't read it, to read it, they have practical strategies that we should employ as clinicians, as a nation, as a community, even the private sector, to improve hypertension control. So it's a priority to control hypertension. I think I've talked enough about that. I mean, I think it's unacceptable that only 1 in 5 patients with hypertension have their blood pressure controlled. But how can we do that? We need to continually increase the awareness through public health campaigns. And I know there's a lot of programs that have been dedicated to that. It actually has an economic burden. I didn't present that data, but when you look at the economic burden associated with high blood pressure, it's enormous. It exerts a huge financial toll on the health system. And when you think about hypertension being the precursor to in fact, all heart disease, then control of hypertension should be a national priority. And as a nation, we are not going to control hypertension if we don't eliminate these disparities. So how do we do that? We need to reach out of our clinical space and develop community clinical connections, create safe environments where people can exercise, provide healthy food opportunities, like an example of the food and medicine program that I described. Use lifestyle change resources, make them affordable and accessible to people who need them the most. And as clinicians, we have to optimize patient care, standardized treatment approaches, team-based care. In my meeting before grand rounds, Greg and April were telling me about the advanced practice clinicians who you all work with. And at Grady, it's the same. We have a huge cardiovascular APP team that works with us, because we have realized that as clinicians, we cannot see all the patients, but having a partnership with APPs, with pharmacists, with the community health worker is only the way that we're going to provide optimal patient care. And of course, empower and equip patients to take ownership of their health. In addition to all of this, we know the struggles and burnout that we deal with as physicians. Is there a way to incentivize blood pressure control? And all of this with the goal of promoting health equity. So many factors influence hypertension control. It's no surprise to you all. When you think about the local community, when you think about provider, what is the awareness of disparities? Are we providing cultural competent care? Is there a sense of trust between the patient and the clinician? And what's the responsibility of the patient? Thinking about medications, thinking about health literacy, thinking about access in terms of health insurance or being employed. And we can't do all of this without change in policy. So we think about healthcare reform, we think about all these national initiatives, we think about Medicare reimbursement, and not only health policy at the national level, it has to go to state, to local. We have to involve payers, employers, private partners. But whatever we do, it always has to center around the individual patient. So the family dynamics, the family support, the social support, even peer support, very important if we are to control hypertension and reduce disparities. So like I mentioned before, I serve as co-chair of the National Hypertension Control Roundtable. My other co-chair is Eduardo Sanchez of the American Heart Association. And this roundtable was convened in 2009 by the Centers for Disease Control, really to address the unacceptable rate of hypertension control. The website, this is a website, hypertensioncontrol.org. The organization of the roundtable consists of both public, private, non-profit organizations, really realizing that if we don't eliminate disparities in hypertension control, we cannot achieve hypertension control nationally. So we realize the importance of dialogue, of partnership, of learning best practices from people who have done it. we prioritize really addressing social determinants of health. So we believe that as a group, to achieve national hypertension control, we have to go where people work, live, play, really addressing social determinants of health and advance patient-centered care. So this is some of the members of the steering committee. Membership is open to any organization. And over the past 2 years, we have worked to, by way of action team, to really advance blood pressure control. So we have the program and practices team and partnership team, really who meet and come. We've been talking about hypertension control for years, but now it's time to move the needle forward and to make sure that we have practical, actionable strategies to move us forward. In fact, one of our goals is that to increase the hypertension control rate from about 50% when you look at the general, to increase the hypertension control rates by a factor of like 80%. And we are constantly like meeting with people, involving new partners to make sure we achieve that goal. So part of what I think now pivoting to how do we get there as a community, as a nation, we have to think outside the box. And I will share with you briefly some strategies that have been, that are backed with evidence that show that these are really important in controlling blood pressure. So I'll start with community clinical linkages, which are connections between the community where the patient lives and clinical sectors to improve population health. So when you think about community, you think about the community sector, the public health sector, and the clinical sector, really forming a partnership to improve patient-centered care. So when we talk about linkages, we want to learn about the community. Most of the times we think we know what is best for patients. We think we know, but it's important to involve patients. It's important to involve community, the stakeholders in the community, to see what we can do to control blood pressure. We have to sit down and agree on what the goals are and find out what resources they need and equip them to really move this forward. I'm sure you're all familiar with the Baba shop trial out of Los Angeles. And what they really did in that intervention, it's an example of a community clinical linkages. They had a physician-pharmacist collaboration, a collaborative agreement that really helped, that used pharmacists to manage high blood pressure. They had an effective blood pressure regimen. I do not want to underestimate the role of medication in controlling blood pressure, but I think that in addition to treating blood pressure with medication, we need a multi-faceted approach in addition to achieve blood pressure control. And all this was taken to a trusted site. You know, they used barbershop. There's a faith trial that achieved blood pressure control by going to places of worship. So I think these components of the barbershop intervention and the success they had really shows us that we need to think differently about controlling high blood pressure. So when you look at the intervention and the control group, they were able to achieve a statistically significant reduction in blood pressure. And at 6 months, whether you were looking at a blood pressure of less than 140/90 or a blood pressure of 130/80, there was sustained blood pressure control or blood pressure reduction. So we've talked about community clinical linkages. I'm a firm believer in team-based care. Our heart failure group at Grady consists of APPs, community health workers, pharmacists, because without that, we cannot move this forward. So in our recent review, we talked about the role of multidisciplinary based care. It has been shown to improve blood pressure control. And really, it incorporates a collaborative and coordinated partnership between physicians, between APPs, pharmacists, nurses, and not to forget the important role of other allied health professionals, such as dietitians, social workers, community health workers, who are often more skilled than us clinicians in addressing the non-pharmacological aspects of blood pressure control, as well as the barriers that these patients face. But like I've always emphasized, whatever we do has to have the patient and the support system in the center. It has to be patient-centered. So just talking about community health workers, we rely heavily on them at Grady Health System. They're skilled health workers, they are frontline. They're non-clinical, but really they're really skilled in what they do. It's a culturally sensitive and effective modality for overcoming barriers that most of our patients face. And we've used them to support self-management of blood pressure. They can be trained in providing education to patients, we train them on self-measured blood pressure monitoring, and they really serve as coach navigators to our patients who are struggling with various chronic diseases. All these principles I'm sharing really apply to any form of chronic disease, including cardiovascular disease. And as I showed before, the importance of social determinants of health is actually in the structural measures for diagnosis and management of hypertension, team-based care. It's one of the things that we have to think about as we think about how do we advance equitable outcomes in hypertension control. So the goals of team-based care, we want to improve clinical workflow, enhance patient education, provide closer follow-up. It helps with medication titration when you have pharmacists seeing the patients through a collaborative agreement. It helps with laboratory follow-up, and actually it's been shown to reduce clinician burnout, because as clinicians, you have limited time with your patients. Even after you see your patients, you have to deal with charting, you have to deal with refills and all of that. But having a team-based approach to managing hypertension actually has been shown to reduce clinician burnout. So this is some data I wanted to share from you that was published in the Annals of Internal Medicine, looking at implementing team-based care. And when you look at team-based care with titration by a non-physician, as well as team-based care by a physician, they had a couple of 10 studies for the non-physician and 19 studies for the physician. You had a higher net change in systolic blood pressure with the non-physician, highlighting the fact that gone are the days when we think that clinicians are the ones that know how to manage blood pressure. I talked in my introductory remarks about therapeutic inertia, being reluctant to escalate care or to, add more medications. In this study, it showed that when you have a pharmacist-physician collaborative model versus usual care, the median days to first goal blood pressure was 36 compared to almost 260 days when a patient was experiencing usual care. With that collaborative model, because the pharmacist can see them regularly, 36 compared to over 100. And they were more aggressive in titrating up medications. In fact, the therapeutic inertia was 27% compared to 44% in patients with usual care. And all this were statistically significant, showing the importance of multidisciplinary team-based care. And when you think about cost, I'm sure someone is asking, is this really cost effective? You can see here how much is gained per quality adjusted life, be it looking at the barber shop study or medication, a pharmacist running a medication therapy management clinic, or even a community-based pharmacy. So I think, if anything, team-based care is important. Lastly, I'll talk about the use of telehealth and other digital strategies, as well as self-measured blood pressure. So when we talk about self-measured blood pressure, which is out of office blood pressure monitoring, we recommend that you combine with telemedicine, because it can be useful for diagnosing blood pressure as well as treating blood pressure, and really helps for follow-up to assess effectiveness of medical therapy. But one caveat is that the use of digital technology may further widen hypertension disparities if we don't assess barriers to effective telemedicine, such as digital literacy and broadband access. And I know that most of you saw all of this during COVID, where we relied heavily on telemedicine. At Grady Memorial Hospital, really most of the telemedicine visits I did were by phone, but we came up with creative ways, especially for our heart failure patients, and to really make sure that we're providing patient-centered care. So providing blood pressure machines, developing a partnership with a mobile integrated health team who will go out to the home to do medication reconciliation, to draw labs, and there's a continuous feedback between the clinicians as well as the patient and the mobile health integrated team. We've talked about, we know that self-monitored blood pressure is cost effective, but we still need to think about the health disparities impact, the access to quality blood pressure machines, that are certified. And when we think about the impact of the COVID pandemic on hypertension disparities, we all know that that has really widened. So it's important that the healthcare systems and payers, they make equitable access to telemedicine a priority. It's listed in the guidelines. Out of office blood pressure measurements are recommended to confirm the diagnosis of hypertension and even in follow-up to titrate blood pressure medication in conjunction with telehealth or clinical interventions. We all know about the validated blood pressure device, but how many of our patients have access to it? Think about the patients you see. Most of my patients are asked, oh, I measure my blood pressure at home, it's normal. And you ask them what kind of blood pressure machine they have. Some of them have the wrist blood pressure, some of them are using, different kinds of measures. But as we think about using validated blood pressure devices, we have to think about equitable access. I've heard a lot of things about, can we, just like we have pharmacies where people can go and get blood pressure machines, can we make sure that pharmacies only provide validated blood pressure machines at affordable prices or even free? So that goes beyond the individual clinician level to partnerships with payers, to partnerships with private organizations. Measuring blood pressure, I will not spend time on that. It's important to measure accurate blood pressure, and there's been a lot of work along the line of teaching clinical staff how to measure blood pressure, and even like patients, how to measure blood pressure. A lot of telemedicine. This came out of a consensus statement, just talking about the different roles that telemedicine can play, not only in hypertension, but in other cardiovascular disease. Benefits, potential benefits, improved access, lower costs. But we have to think about the challenges we face as we think about disparities in access, as we think about data security. At my health system, there's no way for patients to incorporate their blood pressure readings directly into the EMR. We have a roundabout way, like if they use my charts, somehow we can get it in. But most patients come with papers, where you can't even tell what the trend is, you can't tell what the average blood pressure is. So those are some of the challenges that we need to think about. I'll leave you with some best practice strategies. It has to do with healthcare systems as well as community clinical linkages, promoting team-based care. I already talked about that. The clinical role of a pharmacist are really, really important. Developing collaborative agreements, having self-measured blood pressure, but with clinical support. We get all these readings. What do we do with it? Equipping the patient with self-management skills and reducing out-of-pocket costs for medication. We always have to think about that community clinical linkages. Use our community health workers who are really skilled to go out into the community and educate patients and work with stakeholders to address hypertension control. Part of that community linkages are community pharmacists and developing collaborative agreements so that they can run medication titration management clinics. These are some of the approaches that have been shown to reduce disparities for hypertension. And just at different levels, I think I've shown that it's a multi-disciplinary, or multifactorial, multi-level approach that will get us to controlling hypertension. We have to integrate social care into the delivery of healthcare, not only for hypertension. We have to talk about the finances. We have to talk about funding research and evaluation to really assess the effectiveness of all these practices. In controlling hypertension, there are recommendations for race and ethnicity, and I know that that is a hot topic now, kind of looking at all these recommendations and making sure that we're delivering equitable care, really trying to get away from practicing race-based medicine and providing equitable care for all. This is just a comprehensive guideline that summarizes everything we've talked about. We need to measure blood pressure accurately. We need to address social determinants of health. We need to talk about reducing ASCVD risk through shared decision, engage the patient, engage the family, engage other members of the team, team-based care, ensure that digital health is really centered around equitable patient care. We have to engage the health system, payers, employers, leaders to get financial support at every level, and really continually use transparent evidence-based care and assess progress, evaluate our progress. And there has to be accountability at every level. So in conclusion, social determinants of health, I think I've shown you that race and ethnicity is a social risk factor, not a cardiovascular risk factor. The real risk factor is racism and discrimination, and they are now incorporated as social determinants of health. We should routinely consider assessing social determinants of health in our clinical assessment and build on this, develop programs to address social determinants of health. I've shown you the importance of community clinical linkages, the importance of best practices to establish robust community clinical linkages. I think that our future efforts, both research and clinical efforts, should focus on community outreach, taking care to where the patient is, and culturally tailored approaches, including training physicians to provide culturally competent care to address the barriers to hypertension control. I've talked about the importance of team-based care, as well as self-monitored blood pressure in combination with telemedicine to improve blood pressure control. I leave you with a call to action, the surgeon's call to action, that we must address multi-level factors that drive persistent hypertension disparities. It requires a broad array of partnerships and diverse practical strategies that are culturally appropriate. We need a multi-sectoral partnership to achieve blood pressure control. And to reduce inequities, we've got to translate evidence recommendations into practice. In our paper, we say that we have to move past admiring these disparities. Enough of papers that talk about disparities. What are we going to do about it? And we've got to make sure that within the context of this COVID pandemic, the existing disparities in clinical care are not worsened, but we all partner together to provide continuing efforts to promote equitable healthcare access for all. It requires a partnership between healthcare systems and clinicians. And in a recent paper put out by Resolve to Save Lives, they summarize everything and say, this hypertension control should be a national priority. We need to go to where people live, learn, work, and play, and support the hypertension prevention and control strategies, and optimize patient care for hypertension by providing patient-centered care. Thank you.
The problem with Zoom is there's no applause. Modele, that was a fantastic talk. And I love the way that, everything you talked about could be applied to heart failure, could be applied to coronary disease. It's not just hypertension, it's all of the cardiovascular diseases that we treat that it's applicable for. I have so many questions I could ask. I'm just gonna ask, I'm gonna start with one challenging question to you. It's a personal vendetta of mine. Salt.
I was hoping nobody would bring that up. I think that when you think about salt in fact, I think that recently they came out with this salt reduction strategies. I think for me, I look at it as a moving target, right? Initially, we used to tell patients, reduce your salt intake. And then we came back and found out that really people who were recommending that had their own personal goals and all of that. I think that I still tell my patients to reduce sodium intake, because I think that it has been shown that in the DASH diet that helps to control hypertension. But like I said, it's a moving target. We hear everything every day. They're new. I can't even keep up with the changing, policies on salt control.
All right, well, I'm going to start with, there's a question from Chinoso. Can I answer him live? Let's see. Oh no, I didn't do the right thing. Okay, I'm just going to read it. Good morning, Dr. Ogunniyi. There are published data out there regarding relationship of financial and personal health, and those are tied to each other. The healthier one is, the more likely they're to have financial wealth, and the more financial wealthy, likely to have more personal health. How do you feel those factors act synergistically in both directions? On a macro scale, what are your thoughts and ideas regarding this, and what can we as cardiologists do?
Yeah, that's a very good question. I think that it all goes back to the social determinants of health, access and quality of, of financial resources. I think that if people have access to economic empowerment, they definitely will have access to health insurance, they will have access to medication. So all of that tie into having better health outcomes. And to your question, to what can we as cardiologists do? I mean, I think that as a cardiologist, you're in charge of a team. I think that if you view everything has a multidisciplinary team approach. So you as a cardiologist, you don't have time to, you don't have insurance. No, you have a social worker, you have a community health worker, you have resources in your team that you can connect the patients to. But I think that it is our role to identify these things and then reach out to members of our team who are skilled to address this.
Yeah, I think that goes to, there's a question from Jim Kirkpatrick. Great talk. Do you think one of the factors that play a role in the superiority of pharmacist interventions is that they are essentially specialists who are narrowly focused? And part of the problem is lack of this type of specialty care. I think we think of cardiologists as specialists, but I think what you're describing is the members of the team have different specialties.
Yeah, I think that's a good question. I don't really think pharmacists are they're narrowly focused. Well, I guess maybe they're narrowly focused in the fact that they only deal with medications, but I think that I would not consider them narrowly focused because they deal with a whole, the pharmacists that I work with, they deal with a whole broad range of things. Now, apart from medications, they manage like our 24-hour ambulatory, monitoring. So I think that, part of the problem, yes, is lack of specialty care, but I think that just having everyone bring their own specialty or bring their own expertise to provide patient-centered care is important.
I think, so Stephanie Cooper, she works at our catchment hospital, Harborview here. She asks, thank you so much. It seems like flipping our whole model of Medicare must be what we need, rather than patients literally and figuratively walking up the hill. Harborview is up on a steep hill. To get care, we need to be deep in the communities. How do we broadly integrate medical care with community-led health initiatives and be part of the community? And I think I'm going to tie that into a question from Eugene Yang, which is, how do you pay for all of this? How do you pay for these community people, and how do you pay for these food initiatives? And get into it's easy to pay for things we bill for in the hospital, but how do we pay for and initiate things that we feel like are outside of our umbrella?
Yeah, that's a very good question. I think that the ultimate way to deal with all of this thing is to have a policy change to reimburse for community healthcare providing a service. So I'll tell you what we do in our health system. Our health system actually employs community health workers who go out in the community. When we started this, it was done through a funded grant initiative, but through the funded grant initiative, we were able to show value to the healthcare system. So the healthcare system now, for our community health, for our heart failure program, we used to have one community health worker. Now we have two dedicated community health workers for heart failure patients. And then we recently got a grant from the American Association of Essential Hospitals to really look at our heart failure patients experiencing homelessness. Through a 100,000 grant, we're able to fund a community health worker. But these are just temporary solutions. I think that investment of the healthcare system and now forming partnerships with organizations as well as the private and the public care sector will help us really integrate community health workers as well as pharmacists. Some healthcare systems don't even involve pharmacists in this they don't have this collaborative agreement with them. So I think that showing the value, it involves change in healthcare policy. It has to be addressed at a national level. Let me put it like that. But till then, I think that grant funding, showing value to the healthcare system so that they can invest in this. Because one thing we showed was that we were able to reduce our readmissions by a multi host of other things, but including having a dedicated community health worker. And if you think about the cost of a heart failure readmission and investing in a community health worker who can connect this patient to community health resources, or like in our case, we provide the 30-day supply to anyone who comes to Grady Hospital with a diagnosis of heart failure. That really has helped us to reduce our readmission rates. So I think starting at the healthcare system, because nothing that you or I can do as a clinician, then engaging in the larger discussion, with changing policy, with partnerships with payers, with insurance companies. It is going to require a whole system overhaul.
Well, thank you so much. I think that was a fantastic talk. And Tomio has a question on polypills he'll be hitting you up with in the fellow session next.
Okay.
So thank you, and good day to everybody. Happy Friday. Happy May Day soon. And I'll be talking to you later. Bye.
Thank you.